My pleasure.
Okay, great. So we at OBGYNs for Sustainable Future are super excited to have an internationally known expert with us today to answer a lot of our questions and concerns about plastics and EDCs and PFAS and PFOS and some of those environmental exposures that are affecting not only the puberty, timing of puberty, fertility, pregnancy, and I'm sure menopause as well, although I haven't looked into those studies as much. But thank you so much for joining us here today. A brief introduction. You are an internationally known leader in children's environmental health. You're a pediatrician, and your research focuses on identifying the role of environmental exposures in the prenatal as well as the postnatal period for children, with specific emphasis in your past on childhood obesity and cardiovascular risks. In addition to your appointment in the Department of Pediatrics at NYU, you also have appointments in the Wagner School of Public Service and the College of Global Public Health. So obviously reaching more audiences than just the pediatric population or those who are interested in pediatric care. You have over 300 published articles. And one of the articles that caught our eye, obviously, was the one recently on phthalates in preterm birth. As well, you've looked at a number of other chemicals that humans come in contact with and their effects on in utero development, but also children as well. So thank you for coming.
My pleasure. It's great being with you all.
Yeah, we have about 120 people in our membership, but sometimes it's hard to get people on a webinar, but I guarantee you people will watch this later. So I'm going to ask you, first of all, with all these publications, what was the initial spark that made you want to research the effects of these types of compounds on the pediatric population?
So it wasn't a linear path. So I had applied to medical school during then President Clinton's presidential campaign. And the Clinton healthcare debate was raging fiercely. And during my interviews, I kept getting asked, what did I think of the Clinton healthcare plan? In some interview, I don't know what spurred me. It might have been a smart aleck move on my part. I asked the question to the interviewer, so what do I get training wise in medical school to learn about healthcare policy? Complete silence. That was not a welcome question. I don't think I got into that medical school. And that's not why that sparked, but definitely the question itself spoke to me about a need that I felt I needed to address. So I decided I'd gone straight from college to medical school. So I felt like I had some personal time to explore some new opportunities. So I had the privilege of getting a scholarship to go get a master's in public policy, a medical degree between year 3 and 4. That implanted what I might call capital fever. It really got my engagement even higher in healthcare policy, being surrounded by people who are not clinical providers, not even public health people from social policy, welfare policy, economic policy, military policy backgrounds, lots of exposures to people I hadn't really thought about interacting with and with whom I had common interests. And so I decided to, after residency, go spend a year on the Hill working for then Senator Clinton. And I was asked to work on children's and environmental health policies. I figured I had the
Okay.
child health
Yeah.
policy down pat. And the environmental policy I figured I would work out on the margins. And boy, was I in for a surprise. My eyes opened wide. You know, this was the year after 9/11.
Yeah.
So to start with, the senator was very focused on World Trade Center issues in populations living in downtown Manhattan, but she was also interested in everything from environmental exposures and autism to air pollution. This was when there was a mercury pollution coal-fired power plant proposal from the Bush administration called Clear Skies. It really wasn't making skies clear, it was making them darker. But suffice it to say that that exposed me both to the policy underpinnings of environmental exposures, but also the implications at a broad population level. So I realized I could do more with 1,000 people at a time as opposed to one person at a time with a
Yeah.
prescription pad.
Yeah.
So that really was appealing. So I ended up getting some environmental health training at Mount Sinai, stayed on as faculty for a few years, and now I've moved about 60 blocks downtown in Manhattan to NYU, and I've been here for nearly 13 years.
And when you had that aha moment and you started to think about the translation of environmental exposures to the pediatric population, was there another such moment when you thought, well, maybe I'll go one step backwards and look at in utero exposure, or was that in utero focus always on the table?
It was a natural follow-on. I think where I had a second aha moment is actually thinking about all of us. So it's natural to think of early life as a window of susceptibility, and that's where OBGYNs and pediatricians have sing from the same hymn sheet. But what we now realize is that endocrine disruptors affect all of us. Environmental exposures, frankly, affect all of us. That life is a window of susceptibility, be it to endocrine disruption or to just environmental injury and insult. We used to think that adults are particularly just impermeable, that their developmental trajectory is all set. That's just hardly the case now. We had some clues early from the origins of neurodegenerative diseases, but now it's cardiovascular disease. Everything in the lifespan is susceptible. So it's just that there are unique susceptibilities and unique outcomes that follow from earlier life exposures that make us more aware.
Yeah, I actually just attended last week. Ray Dorsey is a neurologist up here at the University of Rochester. And he gave a talk at our local library about farmers' exposures to pesticides and the Parkinson's relationship. But then he also talked about our local dry cleaners, and I think he had everyone's attention.
Oh, yeah.
I should also say that, do you remember Katrina Korfmeyer?
Oh, yes, I know Katrina well.
She says hi, and she wished she could
cool.
attend.
She's great. It's been a privilege. I've known her since I've been in the field.
Oh, wow. Cool. So I found a study of 312 OBGYNs, and only 12% in that study, they only had a 12% response rate, but only 12% in the study had read the ACOG committee opinion on exposure to toxic environmental agents. And this has been something that I've been super passionate about because I feel like it's a little bit of an unfunded mandate in the sense that the list of exposures that we should be talking to our patients about gets longer and longer. And obviously those conversations are not quick or easy. And I mean, we can say really fast, don't microwave your food in plastic, like number one thing. But lead, air pollution, the list is really long. I'm just curious, in your experience talking to various communities, do you feel like the relationship between environmental exposure is more readily apprehended by pediatricians compared to OBGYNs? And if pediatricians are doing a better job, what are they doing? No? Okay.
No. Misery loves company, I suppose. So I think it really goes back to medical education, fundamentally. And medical education, let's face it, is built around treatment. Yeah. It's not built around prevention. So I think we have, again, joint misery with our nutritional colleagues, and the same goes for environmental exposures. If you look at the structure of medical education, it hasn't changed that much from when I was a medical student in the mid-90s. It's lead, air pollution. I think climate change has finally shown up to the dance. Yeah. Because medical students have raised heck about it because they see themselves as the generation that's going to face the consequences of the previous ones and their failure to act appropriately. But if you don't know, we all know this as healthcare providers, you don't know about something, you say, well, it's fine, just move along, or you gloss past it. And the fact is, that doesn't correlate with the degree of impact. that these exposures have on people's lives. And I have worked in my own medical school and with others to try to incorporate and improve the curriculum. I think that we need more continuing medical education. I think we need residency programs to adopt this more proactively. But we've done surveys of pediatricians over, they're now somewhat dated, the ones I've done, but across multiple states. And they show the same story, that they don't know even how to take a basic environmental history. Pediatricians don't. Except for lead. They have great self-advocacy about lead, which is in some ways proof of principle. And air pollution is a close second. But these other exposures fall off the wayside because they haven't been trained. And when you haven't been trained, you don't talk about it.
Yeah.
And this
you don't ask a
cuts
question
across
you
all
don't
the
know the answer
specialties.
to.
Exactly.
Yeah.
And I could say the same thing about supplements as a good example. So again, I think it's misery loves company, unfortunately.
Yeah. Can you talk a little bit? One thing that always I think about when I see patients in triage and things like that is the complexities of obesity and the amount of rise in overweight and obese adults. And obviously that trajectory doesn't seem to be plateauing. It seems to only be increasing. I know you've done a lot of work on obesogens and EDCs. Can you explain to us, as if we were the general public, because I feel like sometimes we need to go back and talk in super plain terms about how an EDC functions as an obesogen and whether or not, obviously the data is clear, but I don't feel like it's accepted. And I actually sometimes have spoken to my patients and said, this isn't all your fault.
Right.
But can you
think it is.
Can you break that down for us, the obesogen?
So let me even take it all the way back to endocrine disruption, because I think sometimes, we think we know endocrinology, but we don't. And it's no offense to our colleagues. It's just, it's a long time since medical school endocrinology. And if you don't use it routinely, I think, and there's also a point to be made here that the endocrine system and our understanding of it has evolved since we were medical students.
Yeah.
So we used to think of endocrine as testosterone, estrogen, thyroid, cortisol, kind of about it. And that would be the end of it. Like maybe renin-angiotensin, aldosterone, so renoendocrine axes would be on the radar. But we now know there are thousands of signaling molecules. That's what endocrine really means. And I don't think in medical school I quite appreciated that notion. So when you talk about signaling functions between organ systems, every biological function can go awry. So it's salt, sugar, sex, temperature, metabolism. You just have to have, and epigenetics really blows up the whole notion of what can disrupt the endocrine system. So if you can program how genes are expressed, two things come up with that. Means that a long latent exposure could cause a long-term outcome that we didn't recognize. And B, it doesn't have to be hormone receptor binding that it disrupts endocrine systems. So we think of brominated flame retardants are a great example. They're prototypical thyroid disruptors. They look like thyroid hormone. It's really easy to communicate that in a lecture audience. When you get to some of the other thyroid hormone disruptors, they don't necessarily bind thyroid hormone or thyroid hormone, they don't work on TSH. They can work in all sorts of genetic and epigenetic pathways to disrupt hormone function. So if you disrupt any type of component of hormone function and contribute to disease, that's endocrine disruption. So I think that's the other context. The second thing I would say is we used to think the dose makes the poison.
Yeah, I saw in one of your writings, you said not necessarily.
Well, and there are now 500 papers that describe that. And I was taught in toxicology, only the dose makes the thing a poison. And it's common sense. And look, it's something, I'm jealous of Paracelsus. For 500, he's got a notion out there that I will never remotely have anything in my scientific publication career that will last 500 years. Maybe it lasts 10 years, to be frank. So if I'm lucky. And so what we now know is that there are superlinear exposure response functions that is steeper than straight lines, which means that the lowest levels of exposure are actually where you have the biggest effects. We know that for lead now, methyl mercury, pesticides, flame retardants. And then we have these roller coaster ride, non-monotonic exposure response functions that have biological mechanisms behind it. If you think of oxygen and myoglobin and oxygen and hemoglobin, it actually makes a lot of sense. They've existed for a long time, but when we think of the endocrine system, we don't necessarily think of that naturally. So you can have receptors that get triggered that compete with each other at different levels. So for bisphenol A, calcium channels for the pancreas, the insulin cells, there's a calcium influx channel that gets activated at low levels of exposure. And then there's a calcium efflux channel that gets activated at high doses of exposure. So that's why you can get this U-shaped non-monotonic dose response function that explains why low levels may actually induce a very sharp response. Mid levels actually are kind of okay. And then high levels, again, spike it back up. And the whole point of nonlinear and non-monotonic exposure response functions come down to a basic problem. We've assumed for many years that you can dose an animal, high dose exposures, and project down to what human experience might be in terms of what will be toxic to people. The fact is, if you have a non-monotonic or U-shaped function, you can't draw a straight line. From high dose exposures can't predict low dose toxicity. So that's the other paradigm shift. We were taught in medical school, everything in moderation, no problem. So to some extent, we were lulled into a sleep that chemicals weren't necessarily bad for us, because at high levels of exposure, yeah, they're a problem, like leads of 80. But now we know a lead of 1 is more toxic than a lead of 0, and actually maybe more important going from 1 to 2 than from 10 to 20. In microgram per deciliter, which is hard to conceive for the average pediatrician, I'll say that. So there has been this paradigm shift. And now we know, instead of, we used to think DDT and diethylstilbestrol were the only endocrine disruptors. Now we appreciate there are 1,000 of them, because we broadened our understanding of what can be an endocrine disruptor and affect human health. And we know that low dose exposures are really a big problem.
But how does that, what can I tell my patient about why her obesity may maybe do as much to her? Because we all have that patient who says,
Yep.
I'm only eating 1,800 calories a day, and I'm walking 30 minutes a day, and and obviously they come in and they want all of their hormones checked, and their thyroid is normal.
Yep.
What can I say to that patient who is struggling, and it might be due to some of these environmental factors?
So I'm glad you brought me back to your first question, because I needed to lay some groundwork and then build to it. So we used to think of calories in, calories out. Again, another common sense notion, but there is a broader, not just endocrine disruptor notion, not just environmental notion of obesogens, things that literally make us fatter. So I'm going to focus on the chemicals, but if you read Bruce Blumberg's book, The Obesogen Effect,
Yeah.
it actually doesn't talk about chemicals only. It talks about a lot of things that are contributing to obesity independent. There's a third leg to that stool, and it's environmental exposure. So let me give you some prototype examples. BPA makes fat cells bigger. Bisphenol is used in aluminum can linings and thermal paper receipts. They make fat cells bigger. They disrupt the function of a protein that protects the heart called adiponectin. It's a synthetic estrogen, and we know that estrogen is crucial to making a healthy body mass. So there are multiple prototype mechanisms by which bisphenols can reprogram the human body so that it becomes more obese to begin with. In addition, and this is where I go back to Bruce Blumberg's notion, There is this other hypothesis called the Barker hypothesis, but the OBGYN population understands at a deep level. So back in the Dutch famine era,
Oh, yeah,
in
yeah.
World War II, right, we had intrauterine growth restriction in a really severe way. And then we realized that all these growth restricted kids were dying at 40 of heart disease and stroke. That's the thrifty phenotype hypothesis. Without anything to do with chemical exposures or environmental exposures, it was just the in utero milieu that
Right.
programmed the body to avidly absorb and hoard calories in a way that was not healthy for the being to have a longer term lifespan, because
Yeah.
that ex utero environment was nutrient rich, whereas the in utero environment was not. And so and now this brings me back to the chemical exposures. We used to think it was just gross disruption of uterine growth, intrauterine growth rather.
Yeah.
But now we appreciated subtle disruptions in growth restriction that can set a child up ex utero to have that thrifty phenotype and have not a heart attack at 40 risk, but a adipose friendly resorption mindset, as opposed to something like you think of your usual, like you have a protein heavy meal, you have a good workout, you think you're going to make muscle, but the body then diverts that because it's programmed, developmentally programmed, to store that as fat instead.
Yeah.
So just to elaborate further about some chemicals that do things like that. So PFAS, the non-stick chemicals used in oil and water resistant clothing and pans. By the way, though, that pan that we think is non-stick, that's plastic, by the way. It's PFAS-derived plastic around a metal can. I think this is the thing that people don't conceptualize. So, like, there's a YouTube channel similarly about an aluminum can you dissolve
I
in acid,
know.
and out comes this wobbly little thing of plasticized water.
Oh,
So we assume a lot of paints are plastic, by the way, just to mind you. So just to
yeah.
get what we assume is not plastic, a lot of nail polish is plastic. It's just polymer,
I know. I keep telling my
polymer
daughter
coating.
this.
But we've been lulled into, oh, that's not plastic. It just doesn't look like plastic. Oh, it's plastic. I mean, all the flame retardant that was added to keep fires from spreading in the 70s in the US all the way to 2013 due to a California law was flame retardant added to plastic to keep it from burning. It never saved lives, and it didn't help, but it was a thyroid disruptor. Those flame retardants set an entire generation of children back cognitively because of in utero thyroid disruption in a subclinical way, not the clinical hypothyroidism that we test newborn babies' blood spots to do, but it set kids up for a lifetime of cognitive dysfunction independent, because we know now that baby relies on thyroid hormone from mom through the second trimester of pregnancy
Yeah.
and
Yeah.
then makes their own thyroid hormone thereafter. So I'm going at a little off tangent from obesity, but let me rope it back in. So the PFAS were found in multiple studies to decrease birth weight.
Hmm.
And then they looked further, those same kids were more likely to be obese.
Yeah. Yeah.
And then in addition, in adulthood, and this is the really disturbing thing, and this comes back to diet and physical activity. So an intervention to reduce weight through healthy diet and physical activity, they measured those serum levels of PFAS, and then they followed the population afterwards. The ones who gained their weight back had higher PFAS.
Oh, wow.
And when they looked further, they found that the resting metabolic rate was lower in relationship to the higher PFAS levels.
Oh, wow. Okay.
And so you can imagine on a cold winter day turning the thermostat. I hate to be really like simplifying this down to simplifying endocrinology to thermostats, but that cold New England day or that cold Rochester, no offense, cold Rochester weekend in February, where the thermostat's turned the wrong way, and you think you're supposed to burn energy, but you're absorbing it and then shivering in the process. You're keeping fat, but not burning energy for the purpose that it's intended.
Yeah. Yeah.
So that's the obesogen hypothesis at a molecular level. It's doing things to send the body in the wrong direction where it's normally wired to have a physiologic response. It's supposed to metabolically respond to the challenge besetting it.
Yeah, but what you're saying too is that even after, or what you're saying is that in utero exposures can basically set the genetic,
Yep.
the protein synthesis up for dysregulation to begin with.
That's the most potent that we understand. The more we study the later life exposures, the more, unfortunately, that I keep realizing, oh my goodness, it's actually as much of a problem in adulthood
Yeah.
as it is in childhood. But the hypothesis is true. I just bring this up because we did a study looking at phthalate exposures, for example, in adults. Phthalate exposures were measured. 10 years later, they were followed, and the 55 to 64-year-olds were more likely to die due to heart disease.
Yeah.
Not due to cancer, due to heart disease, a very specific response.
Yeah.
So, and that means 50,000 adults die due to phthalate exposure every year, $23 billion in lost economic productivity. I'm getting off the child hypothesis, but I want to just keep hammering for everybody in the audience that this isn't just a mom and baby issue. This is something that the partners need to think about. This is something that we all as healthcare providers need to adapt to and understand. And here's the one other reason I want to drive this point home, because it's not obesity related. It's about the reality, as OBGYNs, you get this, that when a baby is born, their ovaries
Right.
or sperm cells
Yeah.
are exposed to the milieu that they had in utero. So the effect of that ovary or sperm cell, the oocyte or spermatogonia, is going to predict that that second generation's lifespan.
Right.
But it's the antecedent exposure 2 generations before that is causing it. So that tells you how much how important it really is to prevent these exposures at all times.
Yeah. And because you said that, you might have seen in my notes that I sent you. I want to put up, I'm going to share screen,
Yeah,
and
please.
I want to show you that oh wait, there we go. Just 1 second here. Let's see, is it going to let me share screen? There we go. Okay. Share.
There you go.
And then okay. Oh wait, what's going on here?
Something is the system setting.
I know, right? This is what I wanted to share. Oh, whoopsie. Wait. Oh my gosh. Did you see this when I sent this to you?
Yes.
So I can't remember which article I pulled this from, but to your, I mean, this shows just from 2000. I did a short literature search looking for a graph that would show us, what the line of exposure would look like before 2000. But that is a pretty steep curve of increased exposure. So to your point, a baby that was conceived around or prior to 2000 now has more and more and more exposures to plastics and pesticides and PET and polyvinyl chloride and all these things. This doesn't look good for human health.
No, and I'm not an ecological person in terms of attributing that directly to consequences. You need individual level data to really confirm that increase is going to translate directly to human health. But we have that evidence. We don't have to argue this. We actually have epidemiologic studies that in individuals connected the dots.
Yeah.
Yeah. And then the more we look at microplastics, the more we appreciate it might not just even be the chemicals used in plastics. By the way, the most science is there. We have a long way to go. I just want to be clear about convincing me that microplastics are what you saw in that New England Journal article that showed incident heart attacks and stroke in
I mean, in the
adults who had,
carotids.
yes,
Yeah, yeah.
when they had measured the plaques, they saw more incident events in relationship to the microplastics. I would argue it's actually the chemicals that are on those micro materials. I mean, we know drug delivery systems are designed this way now. So why wouldn't chemicals be the free riders that are entering cells and causing disarray? But that's in support of the lines you drew.
Yeah, yeah, exactly. Okay, so I want to make sure we get all my questions in because um so to your point about the chemicals that are inside those microplastics, and by the way, as the audience probably knows, that wonderful research that came out of New Mexico and Baylor, where they took 68 placentas, centrifuged them, measured the gas spectrometry, and every single placenta was positive for microplastics. But to your point, it is also the chemicals that are riding inside those little delivery systems. So, you know, you see it in the popular press and obviously in the academic press as well. They say there's, you know, 8,000, 9,000, 10,000 chemicals that we don't know their effects on human health inside these plastics. And so I'm just asking you this as someone who's studied this, and maybe you'll know the answer. Why are there so many chemicals? And do we need all those chemicals? Like, I mean, it seems like you could make plastic with 5 chemicals or maybe 25, but 8,000? What's going on here?
So the fact is that for I don't know how many years, whenever we've gone into the better living through chemistry moment, which probably dates to The Graduate, or at least around the time of the movie The Graduate.
Right.
But, you know, in the chemical era, I'll say it this way, we have had a presumption of innocence of chemicals and their impacts on human health. Remember, the Paracelsus hypothesis was operating. So it was like, yeah, chemicals, schmemicals, they're just little low dose things. It's not a problem. So we've had a regulatory mindset that has matched that perspective. So the presumption of innocence meant that chemicals were allowed to be used with a relatively revolving door. The Environmental Protection Agency, for example, didn't have actually regulatory authority until very recently to ban chemicals. They're only barely starting to ban, you know, asbestos just barely got banned, right? So we've known about asbestos for how many years? So we've had a mindset in general for chemicals, including chemicals used in plastics, that has been, oh, it's fine. And for the Food and Drug Administration, the regulatory framework is still really bad. We still have a authority for a industry-funded scientist to vouch for the safety of a chemical through the Federal Food Quality Protection Act, called generally recognized as safe. So many chemicals used in food packaging are still allowed to be vouched for as safe. Well, I think it's safe, therefore I sign. And that's it. And then the FDA has to go through this whole process, and the presumption of guilt, of burden, the burden of proof is on the public and the regulatory agency to prove that there are effects in the first place. And that's just not logical.
No.
But it's where we're at in 2024. So we have 16,000 chemicals used in plastic materials, at least based on the latest estimate. And we have toxicity testing data for a subset of that. We have human epidemiology in a small number of that. And we're barely, the ones we already have concerns about, we're in a tug of war with the chemical industry, fighting back against. I've been at global plastics treaty meetings, we can get to that later, where I've had countries declare there are no health effects of chemicals used in plastics. Full stop. I'm talking about Japan.
Whoa.
I'm not talking about I think we're not talking about
Less industrialized places.
exactly. We're not talking about folks where the EPA is one person or maybe it's not a knowledgeable scientist. This is where you also have manufactured doubt. You have
Yeah.
companies pushing an agenda saying, no, 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 this scientist is full of hogwash.
Yeah. Well,
And
we saw
yeah,
what the appeals court for the fifth district did just a couple of days ago with the PFAS in the food packaging, and they were like, no, you can't. We're gonna put a halt to that because I think it was passed like maybe 2 weeks ago or something like
yeah.
that. Yeah, I mean, it is 21%, right, of GDP, the chemical industry.
Well, so I'm not convinced that that's true. What
Okay.
I've heard different numbers. I have heard that and this is what really bothers me. I have heard that the plastics industry is $750 billion a year. And we did a study documenting that the health costs, the cost of human health consequences related to plastic are 250 billion a
I saw
year in
that.
the
Yeah.
US alone.
Yeah.
So from a pure like why are we doing it perspective, if you are profiting and you're losing a third of your profits in the population
Yeah.
due to disease and disability, something is not right here. And if you're talking about something that's equivalent to 5% of US healthcare costs, that's pretty alarming.
Yeah. No,
Uh,
I I include that study in my grand rounds when I give it. Um, well, and the other thing, Jill Filipovic, I don't know if you follow her, but
yes,
she she posted today like no one's really holding Big Ag accountable for the fact that Novo Nordisk and the makers of these GLP agonists, it just like the only people that make any money off of all of this unhealth in society are the capitalists or the big corporations, and
right,
rather than addressing all the dysfunctional ways that we handle our food, the antibiotics, the
right.
plastics that they're wrapped in, all of these things, well, let's just get a shot, get it, and
I'll give you a disturbing anecdote that
okay.
precedes that. So, Eli Lilly makes atrazine. Atrazine is it's an herbicide that's used pretty widely. It's substantially in the water supply. It's an aromatase inhibitor.
Okay.
It obviously is known to be a carcinogen and particularly a breast carcinogen. And my understanding is letrozole. I don't think it's widely used as the chemotherapeutic agent made by the same company counteracts aromatase inhibition.
Oh, wow.
I might have my inhibition activation inverted, and I apologize if I'm being a little glib. I can't remember in real time. But the point is that you have a company that makes the problematic chemical and makes therapy for the problematic chemical.
Yeah. Yeah.
The
that
left
pretty
hand
much
doesn't know what the right hand is doing.
that pretty much summarizes where we're at.
Yes.
Okay, I have to ask you this question because I took it personally. When your phthalate and preterm birth study came out a month or so ago, I was sharing with a colleague how excited I was that the study was published and that we could talk about this. And my colleague, who's a specialist, I'm a generalist. My colleague was like, Jane, don't confuse causation with correlation. Um, and
Oh boy.
I was like, but it was in the urine, like they measured it. It was in the urine. She was like, Jane, no. And I was so devastated because I'll be honest, Leo, I haven't been in academia that long. So I'm like scared of being seen as not smart enough. But anyway, what would your response be?
So you're smart enough. And let's start there. The second thing I'm going to say is I'm never going to tell you any of my epidemiologic studies prove causality. But let's bring this all the way back to Sir Austin Bradford Hill, who defined that causation and the principles of causation. In that landmark lecture, which by the way was in the tobacco era, that was the stimulus for his talk. he talked about the principles of assessing causality. He never said causation was yes or no.
Mm.
It always was shades of gray. And then he said something really important. So, so there, we have to look at what the context is for deciding how much evidence it requires for us to act. What evidence is sufficiently causal, an adjective, not a noun, to support action at a governmental or clinical or whatever level.
Mm-hmm.
So, and the example he used was a carcinogenic dye in industry. And he said on fair evidence, you might act. Whereas if you're telling people not to eat food that's colored red, and as a redhead, I take offense at that, but that's a different discussion. You might need a lot of evidence because it's something that is affecting, a personal style thing, and the stakes are not high. But when you're talking about cancer in people, workers, the stakes are really high. When you're talking about premature babies, the stakes are high. So let's take a step back. Let's accept that evidence is limited, even though it's from a population of 5,000 from 14 different cohorts. It is an observational study. But let's talk about randomized control trials vis-a-vis observational studies. First of all, you can't do a randomized control trial unless you intentionally dose people with the exposure.
Of course, right. Yeah.
So you already are at observational being your cap level. I don't have the benefit of running a drug trial. There are very few studies that have tried to reduce exposure through interventions. We need more of that. I would accept that you can do some interventional designs. They're very limited in being powered to achieve a clinical endpoint and outcome. But there are good observational studies and really awful randomized control trials. It's all about confounding. So first of all, that's a point I want to make, is that there are really strong observational studies, and I'm not even arguing my observational study is a very strong observational study. Let's just accept it's a good observational study. Let's just call it good. There are how many different studies that have documented phthalates in preterm birth? I think we're at over 24 at this point. Then you have the laboratory studies. So I think there's an important point to be made about concordance of evidence. You have animal studies showing the same effect as human studies.
Right.
So when you have that kind of consistency of evidence, you start to have a concordance of knowledge that supports the hypothesis that is it causal? I'm not going to get into that adjective. I'm not even going to use the noun ever. It's about probability of causation more than causality as a yes or no.
Okay.
And it's about what the stakes are for action. So with all due respect to your specialist colleague, they have the notion of causality wrong, and so many people do, unfortunately. They don't really understand what the point is because we've been brought up in a drug trial mindset where you need causal evidence to support a drug use, as opposed to, and then that leaves aside the whole mechanistic evidence thread, which is a third pillar of evidence supporting the notion that phthalates contribute to preterm birth. Oxidative stress. You don't have to argue with endocrine disruption. I'll even step aside from endocrine disruption. Just talk about oxidative stress in the placenta.
Yeah.
Phthalates contribute to oxidative stress. Oxidative stress is bad either if it's premature rupture of membranes, preterm labor, or dysfunction of the vascular tree, period.
Exactly. Well,
so you have this triangle of evidence supporting the notion.
Well, the reason that I actually got interested in all of this a couple years ago was because I was like, I have a service and I have, 10 patients on my service and 8 of them have preeclampsia. I was just like,
Wow.
I mean, Allie doesn't deliver babies anymore, but Marie can probably agree. I mean, we haven't seen the CDC, or I haven't at least, data for hypertensive disorders of pregnancy since 2022. So, I feel like it's been a while. But I can't imagine the rates. I mean, sometimes the entire service has gestational hypertension, preeclampsia. And when I say preeclampsia, I mean, bad, like, transaminitis in the 800s, or, hypertension that can't be controlled with 3 different agents. I mean, nothing like it was. I mean, I've been doing this 20 years, nothing
Yeah.
like it was 20 years ago. So,
Well,
anyway,
and that can't be genetic change.
no,
And I'm not telling you I know every risk factor that's characterized. Um, and it's really death by 1,000 cuts.
yeah.
Quite literally, in the case of preeclampsia, we know that that kills mothers to
Oh,
be.
yeah.
Um, and nothing I'm talking about when we talk about 5% of premature birth and we talk about 3% of preeclampsia being due to one chemical agent. That's what you would expect. You would expect a multifactorial condition to have lots of pieces to the pie. I'm not suggesting that 70% of anything is related to one chemical exposure or one
Right.
environmental exposure. Far from it. The fact is, we've got 100 or so, I don't know how many, environmental exposures that are adding up, be it air pollution,
Right.
which by the way is increasingly plastic air pollution, as well as carbon fossil fuel based direct burning of fossil fuels, which by the way is plastic indirectly because fossil fuels are the feedstock for plastic.
Yeah.
But I think you get my point is that nothing, and I think this is where people get misled into thinking, yeah, what environmental, you're just wrapping yourself in a green cloak. The fact is that we're not talking about everything we do doing to one silver bullet. There are multiple bad bullets that are riddling patients' lives.
Yeah.
And some of them have already hit and run. Some of them have already caused their damage. I'm not even suggesting you can observe them in the pregnant woman. It may have actually been their antecedent exposure.
That's right. Yeah, exactly. So for our viewers, I do recommend, I read Mark Simon's book about microplastics. You can go to my Twitter. I have my pinned tweet is to sign the petition to not exclude medical plastics from the Global Plastic Treaty. And you have until April 10th to sign that. Healthcare Without Harm is distributing that. And then I just have a couple rapid fire questions.
Yeah.
I
Okay.
have one as well.
Okay, cool. So
Okay.
so after that study came out showing that researchers in China boiled the microplastic water or boiled water that had microplastics in it, and that calcium carbonate encrusted the microplastics, and so that would be a way to cure yourself of microplastics in your water. And I thought, wait a second, I thought heat was the worst thing you could do to leach out all the chemicals in the plastics. And so all my friends were like, see, Jane, you don't have to worry about microplastics. You can just boil the water.
Yeah.
And I was like,
there's no support for that notion working.
okay.
Full stop. I mean,
Full
I've
stop.
seen the study. There are so many other studies that show these chemicals leach out, and they didn't measure the chemicals leaching out. They just said that they're encrusting the microplastics. We're talking about two different things. We're talking about the microplastics as opposed to the chemicals used in plastic materials that already absorb.
And to your point with the carotid, same thing. Okay, can
Yep.
you let us know whom else we might want to interview on this topic? Because I feel like I want to just get more and more information. Do you have someone that whose research you really like?
So, there are Sheila Satananarayana is another pediatrician whom I respect in the field, who together with Shauna Swan have done a lot of reproductive toxicology. And Shauna is a former Rochester person.
I know, right?
I think why am I drawing a blank on one of your colleagues from ACOG, who was an affiliate representative to our environmental health executive committee. I'll do that offline.
Yeah, that's fine. I think he might be.
Nicola.
Yeah.
I got it. Just on the
He's not really, yeah, he doesn't do, he's more of a, he's like me. He's not in an academic setting.
That doesn't mean he doesn't understand.
No. I know. But you kind of have to be affiliated.
You're super sharp on this right now. I mean, there's nothing here that you're selling yourself short.
My last question, and then I'll turn it over to Ali. If a resident came to you and said, I want to do a research project with OBGYN looking at environmental exposures,
Hmm.
what would be something that you've maybe thought of that would be, how residents, they want something they
Yeah.
can in a year or two?
So they're always welcome to reach out to me directly. We've always got a lot of people who can do virtual or peripheral projects related to what we see. The ECHO program, the Environmental Influences on Child Health Outcomes program, doesn't have our group. It's just 30. Just 31 or so centers across the country. They're doing this kind of work. They're all across the country. Um, I think um, I'll put in just a random plug for my own book on the endocrine disruptor thing, just as an aside, called Sicker, Fatter, Poorer. I'll get the book here in a second since you're doing video. Why not? I wasn't quite prepared for this. And I'm not saying this is the end all be all, but it is a pretty accessible book for
Oh,
lay
fantastic.
audiences
Okay,
on the
great.
topic. But I wrote it with I think I wrote it for the lay audience, but it ended up being a book that a lot of clinical colleagues come to me saying, like, yeah, this is actually pretty accessible and starts me at a level and gets me past some of these clinically causation kind of arguments that you see drummed up around there. But in terms of research, a lot of the researchers that I love and respect are profiled in the book. It was a little bit of a
Okay, great.
labor of love getting to know the people that are described in the book. So they're also available, great people like Tom Zeller, who's now retired, but he's at UMass. He's a thyroidologist who did some of the very important studies identifying environmental neurotoxins and the effects on the brain. But I know Allie's got a question and I'm running
Yeah.
you over because we're having such a great conversation.
Yes. Thank you so much. I mean, I can't tell how many notes I've written, and this was so helpful. And my research is on the flip side. Jane and I are a nice complement because she knows all of this, as you can tell with all of her questions. But I researched, medicine and our footprint, and our contribution to all of this. And so a lot of what I work on is trying to get rid of single-use items and getting rid of plastics, and it's the cost and the waste and, the production, et cetera. My big question for you is this data, all of this, all of this, how do you put into a palatable form for administration and or industry for the next steps? Like I struggle with, do I do advocacy or research? I think I need research because we need more data because that's going to drive administrators. So that's what I do. But how do we take this to minimize our use in plastics and these chemicals in the medical industry?
Well,
I know.
we already talked about healthcare without harm. They've really led the way in putting out there some pathways by which healthcare systems can really adopt sustainable practices. I know they've been mostly focused on climate, but they're increasingly adopting a mindset that includes single use, particularly, but medical plastics as well, and using plastics that are freer of the chemicals of concern that we've talked about. That's the initial step in the conversation. I think that awareness is really the formula to success here. And so getting it in medical education and getting it, the good news here is that the medical student generation is aware and awake to the notion through climate change.
Right.
And again, as I talked about, plastics are an intersecting phenomenon with climate change in that fossil fuel production is the core to both challenges.
Right.
Because fossil fuel feedstocks are the plastic feedstocks. And they're also driving climate change.
All right. Sounds good. Yeah, I'll keep on one OR, one hospital at a time, and I'll report back.
Yeah,
it's hard work.
Allie's doing some really great work showing how how to reduce plastic exposure for the OBGYN. And she actually had a great publication in the American Journal of OBGYN called Greening the Operating Room, or Greening Gynecology.
Going green in gynecology.
Going green in gynecology, yeah. So lots of checklists and ways, little ways that you've done, Allie. What was the most recent research you presented? Was it on the manipulator?
Yeah, a device that we use in hysterectomies. I compared two totally disposable devices, one, half reusable, half disposable, one reusable device, and the carbon footprint was, 4.5 times lower for the reusable steel device. And when you compare it over 300, cases, it can save, up to $40,000 or as much as $15,000 or $25,000 for some of these other devices. So like, administration cares about money, obviously. So, using reusable is a lot of wins, and not using the plastics, that getting us back to this whole conversation in those devices and all of the other chemicals would be a huge win. So,
yeah.
Yeah.
And I'm teaming up with our...
The money argument shouldn't be the core driver, but it often is. And it's often the secret sauce to getting what you want done.
Mm-hmm.
And we're going to meet with the medical students that are interested in sustainability. They are going to help me. I've been pushing to have us get rid of the plastic speculums. We're kind of halfway through an LCA on them, and we found 2 little nickel cadmium batteries in each lighted plastic speculum.
Oh boy.
Anyway, it's hard.
Yeah,
it's really hard.
It is.
Anyway, thank you so much for your time today.
Thank you so much.
My pleasure.
And Marie, did you have anything you wanted to ask? If not...
No, sorry, I've been starting another meeting, but thank you so much. This is definitely a big interest of mine, and has been super helpful and interesting. Thank you.
Okay.
My pleasure. And if it can be helpful to you guys in the future, would love to keep collaborating in ways that make sense, because we have to support each other.
I love that. Well, I think I'm going to talk, come up for grand rounds. So
that'd be great. I'd love it.
All right.
Awesome.
Fantastic.
All right.
So nice.
Thank you so much. Have a wonderful day.
You too. Thanks. Bye-bye.
Bye.